I'm going to hand over now to Dr. Tracy Tay, who is going to lead us off the facilitation for our final Rockstar panel for the afternoon, where we're going to really just get right in there and tackle the meaty issues of change, changing the system. Thank you to all for joining.
I'm an anaesthetist and also an executive director at the New South Wales Agency for Clinical Innovation, and it is a great honour to facilitate this session. I was thinking to myself when I was listening to Jill that I think the only thing I had in common with Jill was that I love red nail polish too. So I'm very glad that I could find a connection there. But I'm sure you're like me, completely glued to Jill's session, and I can only say, Jill, that your contribution today has been anything but small, so thank you. For this last session, it's been absolutely essential that we bear witness to the pain, to the fear, to the distress, and sometimes the anger that health workers have felt this year. And also we have to acknowledge that this has happened on a really long background of burnout and poor mental health in pre-COVID times. So this final session is really about looking to the future. What next? What's the future for us? We have to continue to do all the things that we've spoken about today. We have to look after ourselves, and we have to look after our friends and our colleagues. And we do need to have our own personal toolbox of yoga and meditation, exercise, family. But one theme that we've kept coming back today is that making workplace wellbeing an individual responsibility alone is just not going to lead to the sustained, significant change that we've been talking about, that Jane's spoken about. It is necessary but not sufficient. So what we want to cover now is, what is it that we need to do to change our environment and our system, and sustainably? What are the very practical steps that we need to take? And we fortunately have a brilliant and very experienced group of panel members, and I'm going to ask each of them to briefly introduce themselves, because I'd like them to highlight what they know they bring to this conversation. So Marie, would you like to start? Marie Bismark.
Hi everyone, what an extraordinary day it has been. I'm Marie Bismark. I'm a public health physician. 20 years ago I used to lecture in pandemic law, and I never thought that I would be living through a pandemic. I also work as a junior doctor as a psychiatry registrar with Melbourne Health, and I was working in a clinical role all the way through the pandemic. I head up a research team where I have a NHMRC investigator grant to look into the connection between practitioner wellbeing and patient care. And finally, I'm a company director, so I serve on the board of the Royal Women's Hospital in Melbourne, and I'm also a director of a large aged care company where we care for around 6,000 elderly residents.
So you're still standing, Marie. Clearly an underachiever. Omar, please introduce yourself.
I think I might be almost as busy as Marie. Thank you very much for having me today. I'm an orthopaedic surgeon from Perth and currently president of the Australian Medical Association. So my background, just briefly, I'm an orthopaedic surgeon. I'm I guess a manager there. I run a department at Fremantle Hospital, and I'm the lead surgeon there. And I've spent probably a decade looking at or being involved in orthopaedic education, and spent 4 years running the training program during a period of enormous change. I think we all recognise the impact that our college training programs have on our junior doctor workforce. I've been involved in the AMA my whole career, so 20 odd years now, and have taken various roles along the way there, and culminating obviously at the moment with a couple of years in the sun as the federal president. Now, in all of those roles, I've observed actually a lot of change. I've been involved in leading it in many examples, and I think how we as a medical profession are able to drive changes is a critical thing to talk about. And I guess the last thing just to mention is that although I've spent a lot of time advocating for doctors, including as an intern and RMO, what we never talked about back in those days was actually our mental health. We never acknowledged our own frailties. We did complain. We complained about all sorts of things, but we didn't actually acknowledge our own humanity, I think, a lot of the time. And that's a massive contrast, I guess, to the conversations that we're now able to have as a profession. And I think that's actually a huge benefit to the profession and our ability to look after our patients. But it's also a challenge, I think, as we're having these conversations, in how to make sure that we don't let any of it get out of hand. And we remember, in fact, that we're incredibly privileged, and we need to find that balance, I guess, in our work. So we're very keen to participate in today's discussion. Thank you.
Thanks, Bethan. Would you like to introduce yourself, please, Bethan Richards?
Thanks, Tracy, and hi, everyone. It's so wonderful to see such a huge amount of people here today to talk about this incredibly important topic. So I'm a rheumatologist by training. I'm the head of Department of Rheumatology up in Sydney at Royal Prince Alfred Hospital. I'm also paid 0.5 to be the Chief Medical Wellness Officer for the district. So I work in Sydney Local Health District, which has 4 hospitals, I guess, under our umbrella. And as part of that, we've been focusing on addressing wellbeing. And so I have set up a WellMD Centre that I'm the director of, and work with a team now to look at, the question that we're here to answer today is how do we take the theory of what, we think we know we should do and actually make it work in, the types of stressed environments and the complexity of healthcare environment that we all have. So I've had that role for the last 3 years now. My background's in education and training, and I've had a wealth of experience over the last few years flying around to hospital boards, speaking to colleges and to a variety of other stakeholders in trying to help sell the why and convince people that they need to invest in wellbeing and what that might look like, and try and give them some tangible things to hold on to going forward about how do we actually meaningfully and sustainably address this issue long term.
Thanks, Bethan. David Clarke, would you like to introduce yourself?
Yeah, hi everybody. Yeah, look, I'm currently the Chief Executive of the Australian Institute of Health and Safety. I come from a really diverse background. I'm an expert about probably absolutely nothing, and I know a bit about all sorts of things. That makes me a bit dangerous if you understand the Dunning-Kruger effect. Every now and again, I think I'm an expert about everything, but that's obviously not true. Look, I've worked in small, medium and large enterprises in leadership roles as a board member. I've been across the public, private and community sector. I've worked in disability, in mental health, in environment, more recently in health and safety. And prior to the environment work, I was in the employment sector, and I've also started life as a potter as well. So I've had a pretty diverse life. And I suppose what I bring to the discussion, aside from the fact that I'm very much within the space today of looking at the health and safety of workers within Australian businesses, is probably a systems perspective. I think it's that diverse exposure to different kinds of systems. Jill made a comment about stepping back and looking at the big picture. And this is the moment, this is a session where whenever you look at the big picture, you step back and you see if you can widen the scope of your vision. One of the benefits that I've had in my career has been coming into a different field and looking at it naively. That field is full of experts in the field. One of the interesting things about culture is that the people inside the culture, whatever that culture is, aren't the best commentators about that culture all the time, because it's a little bit like the forest and the trees. So I think each of the areas that I've come into, the earliest work that I've done in each of those fields has been possibly the best, because I've brought the naivety and fresh eyes to that field and made observations that, in some ways were obvious to an observer from outside. So that's what interests me at the moment, my recent work around hospitals, in particular in regard to COVID-19 and the massive numbers of healthcare worker infections, and what we found about hospital and healthcare culture.
Thanks, David. You've described an extremely unique perspective, and started to tell us a little bit about what you've seen coming in from that, with that outside perspective. Could you give us, could you expand a bit more on sort of the high level principles of what you've observed in healthcare during the pandemic?
Well, look, the perspective I'm going to speak from is from a health and safety perspective. Okay, so when it came to COVID-19, you know, my current work, it's very, very important. You try to focus on, you know, COVID-19's got so many domains, it's got so many dimensions. The institutes tried to focus on the issue of workers and their health and safety. And of course, it's the healthcare sector and the aged care sector, and to some degree, food processing and a couple of other areas that have proved to be extremely high risk in COVID-19. But I suppose I'd start off by saying what's really, really clear today is that there are a lot of people outside the healthcare sector who think and assume that workplace health and safety in hospitals is good. And I assert, and it's a blanket statement, so you can imagine the exceptions to this rule. And we should imagine exceptions to a rule because you can apply a bell curve over almost anything in life. But broadly speaking, it's a myth that workplace health and safety in hospitals is good. And it's a myth that continues to be perpetuated because of the structures that exist that work against good workplace health and safety. And I think COVID-19 has really found that out more than ever before, and made that more obvious to people. And it's put the whole system under a fair bit of pressure. And that's the perspective that the Institute's been trying to bring to this issue. It's a cultural issue and requires a cultural response in terms of changing culture.
Thanks, David. I can almost hear everyone saying, it goes to one of the conversations had earlier this morning about what can I do as an individual? You know, there's clearly some principles that we should be following, but how do we do that? I might move to Bethan because Bethan has taken this challenge on, and it'd be great to hear a bit more about what you've been able to achieve, Bethan.
Yeah, thanks, Tracy. I can hear people asking, you know, one of the most common questions I get asked is, where do you start with all this? And I think, you know, people out there in the audience today will be at various stages. There'll be some of you that, you know, really now have a passion for this and want to take something into your organization. There'll be many people that have already taken steps, and how do you take something that's on a small level and take it to a large, you know, organizational and a sustainable level. And I think if you go back to the basics for those sort of starting out there or rethinking your approach, the very first thing and the most important things, and I think the key to our success in Sydney Local Health District, is that you have to have executive buy-in. And that may be easier for some than others. But if you can look at trying to find an executive sponsor, find out, you know, who's got a similar interest area, because this is an easy issue to connect on. And I can tell you, you know, the administrative staff and our executive staff have just as much burnout at the moment. And so the understanding and the appeal and trying to translate the language around this is probably easier at the moment. So I think there's an opportunity there. In terms of, you know, trying to get their buy-in, there is nothing more powerful than local data. So when I first started, I was really relying off, you know, international data or the Beyond Blue survey from 2013 that everyone quotes at every presentation that you go to, because we just haven't had bigger series data on a really large scale. But I can speak to the fact now that if you have local data, even in a small amount, it is incredibly powerful at trying to engage people. So you can either do that by doing some basic surveys of your environment, or you can use what's already out there in a way. And so if you don't know where to start, there are already surveys like the AMA's Hospital Health Check would be an example of that. The People Matter survey if you're in New South Wales. And these are things that the administration and the chief executives have on their KPI list that they're accountable for. So I think if you know the levers and what is important to your administration, you can look for win-wins. And at the end of the day, you know, that's what we're trying to do when we're trying to get people on board, and we're trying to look for win-wins together. I think the third thing that I would do is to think about your why. It's really important to get your comms messaging up front really straight, and the comms messaging that you're going to use with administration and executive staff is going to be very different to what you're going to use with your frontline clinical staff and even with your senior doctors versus your junior doctors. And what I found really helpful there is to spend some time thinking about the why behind this. And I think, you know, you've done that today. And hopefully everyone's a little bit on the same page of, you know, the importance of this as a hugely prevalent problem, but it's linked to quality and safety, and work health and safety, as we just heard from David, is something that really pricks the ears of not only hospital executive, but hospital boards. Because that's the one thing that hospital boards are civilly liable for. Work health and safety is something that is a significant lever that way. I think not forgetting these people are human beings. And so if you can bring some form of storytelling to, you know, the cell when you're trying to do it with administration staff, we've all got stories. We will have local stories. And unfortunately, you know, most of the time we get impetus to do something when something tragic happens. And we don't want that to have to be the case. So we're trying to, I guess, get ahead of the curve, but really selling the why. And why is this important to people based on the language that they will understand? I think the financial agreement, you know, is obviously something to talk about, and the business case for wellbeing is, you know, easy in one way, but in terms of getting local data for that, that is something, if you can do, it's incredibly powerful, because you'll often have your CFOs in these conversations. So thinking about that, you don't have to reinvent the wheel with a lot of this. You know, for those of us that have had some experience, I'm very happy to share our business cases and what we've done and how we've tried to cost this. I modeled off what Stanford did. They shared their information, and then we did that here. And I think if you can do that and link, you know, this why to your organization's KPIs and your organization's strategic plan, you can really bring your administration on board. So they'd be the, I guess, the top tips to think about up front as to how to get your executive buy-in and bring in your administration.
Thanks, Bethan. Omar, as you're taking on this new role of AMA president, you're going to have the opportunity to influence beyond our organisations. How have you thought about that? And you know, how do you see your role, and what levers do you think exist that can influence and drive change?
Yeah, thanks, Tracy. I think the AMA actually has a really important role here. We have a pretty strong voice. The media, governments, whether they be state or federal, colleges, associations, people tend to listen to us, and I think that's probably our biggest lever as an AMA. But we are also the voice for the whole profession, and I think that's another important point, because there are different perspectives on many of these issues in different pockets of our profession. And we see strong action from some and almost belligerence from others. So that there's a role there for the AMA. In terms of me, I think my role is leadership, you know, within our profession. We do have a responsibility to call out problems as we see them and to hold people accountable. And I'll give you some examples of that in a moment. We are important as advocates for change, and also to empower others. And in particular here, I'm talking about the next generation of our profession. And that's something the AMA has done a pretty good job of in the past. But I think at a hospital level, we need to remember that we are all leaders in this profession, and we need to ensure that that everyone within our profession, including our most juniors, including our interns and our students, are understanding their leadership roles, because I think it helps them cope in these pretty tough environments that we're in. And the AMA is in a unique position to leverage all these relationships and our media power in order to create change. And that's certainly what I'll be trying to do in my 2 years. And we have seen this year, you know, an incredible change. It's external change, it's imposed, and we feel like we're out of control. But then on the flip side, we see the other areas where we've wanted change for a long time and it's glacial, it's impossible, it's so hard, or even it's actually heading in the wrong direction. And when a system's put under stress, you fall back on what are your true values rather than what most of our health services say are their values. I think that's something we need to call out as well. So change, that kind of change, the change that we want to achieve is hard. It takes a lot of time, but I think we do need to be patient. It is happening. And I think we shouldn't get too depressed, I think, when we look at the negatives of our system. There's a lot of negatives, and as has been pointed out, perhaps workplace health and safety is a myth, but at the end of the day, if you look at what our hospitals were like and our workplaces were like 20 years ago, they were different to now. There's a lot of change that has been achieved already by people like us having these conversations. We just need to keep that going and do better. So in terms of levers, there are some, I'll give you some examples of some levers that we've already used. So the hospital health check's already been mentioned. So that came out of WA from our junior doctors. And what that's done is just surveyed doctors and enabled us to shine a light on the actual experience of doctors in hospitals. And it's a really strong platform for advocacy. The hospital boards listen to it and they change. And a really simple example of that is one of our major tertiary hospitals, which scored very poorly. They were embarrassed that they saw themselves as a leading hospital. They scored very poorly across a range of domains. And they took it on board. The executive did a couple of very simple steps, one of which was trying to ensure doctors got leave, but the other was to employ a wellness officer, wellbeing officer. And I have to say, I used to be a little skeptical of that kind of role, but within a year or two, that hospital was a top scoring hospital from junior doctors as to how they felt supported in their workplace. Another example where we can call things out is our culture and engagement survey that we did in WA a few years ago. We had a lot of problems in one of our major paediatric hospitals, and to the point where the workforce was rebelling. The doctors, the nurses, everybody was rebelling, and nothing was happening. The AMA had to step in and force change, which we had to do, unfortunately, in the public eye. But it led to a fundamental change in that institution that is now completely different culturally, different people in the executive. They had to move on. And sometimes that is what has to happen. You have to move people on. But we've now created a caring environment where staff are giving much better feedback as to their experience compared to before. Another example, just yesterday in South Australia, our South Australian president managed to get into the South Australian Healthcare Governance Bill a legislative requirement for hospital boards to promote healthy workplace culture and to implement and promote health, safety and wellbeing measures, including psychological wellbeing. So that's just yesterday in the Parliament of South Australia, that bill has now gone to its third reading. So that's an example of the AMA just writing a couple of letters, having good relationships and going in at the very top level to try and then push that change down through the system. Now, of course, we have to work from the other way as well, but that's another example of a lever that we can use. We've also got industrial agreements, lots of levers there for us to create space for people to have conversations, to talk about things, for leaders, for managers to have the time to talk to their staff and explore what's going on rather than it all being driven by incredible pressure on workload. And so I think incorporating these issues into our industrial agreements is another key lever. We've been a little bit involved in PPE, but I think David's done more of that than us, so I'll keep that quiet. We also do work through colleges, making sure that behind the scenes, all of our leading organisations within the profession are coming on board with this kind of cultural change that we need to achieve. But the last thing I want to say is we do have an individual responsibility as well. As I said before, we are all leaders, every single one of us. There are people watching us. And I think having conversations regularly, reminding ourselves that we need to model the behaviours that we think are important, that's how you achieve cultural change. You actually have to change your behaviour first. And if we can get those behaviours changing, the culture will actually follow, in my view. And it's something that we've just not really looked at, I think, enough in the medical profession. Very last point, I do think we need to look at what our leaders of the future look like. In the past, we've looked at clinical excellence, people who are great scientists, who are great clinicians in terms of their technical abilities. We also looked at managers who are able to lead groups because they can manage complex tasks. But I think there are other skills that we need to start valuing in the medical profession for our leaders, compassion, flexibility, communication skills, capacity to achieve change through leadership. And I think if we can foster those skills within our workforce in its entirety, we're going to see a better future. Thanks.
Thanks, Omar. I know David wants to make a point. Can I just say, though, what you just said there resonates a lot with what Susie New mentioned earlier in the day around professional diligence and integrity. And I think one of the things that I'm enjoying seeing in your positivity is that many of the leaders that we watched as we grew up in medicine, we looked at them and thought, we don't want those jobs. They look terrible. They look tired. They don't see their families. They're unhappy. They're there at all hours of the night. And I agree with you. We need to role model jobs that people want. And so I love your positivity. David, you wanted to make a comment.
Yeah, and not to be negative, because what I notice is that there's a tremendous groundswell of desire to improve healthcare and healthcare environments for patients, for workers, for everybody. And there's a lot of movement at the station around that, particularly at the generative area of like where it's happening on the ground. And today's had some inspirational contributions around that. Culturally, those things, people are doing that all the time. And if the leadership frameworks and structures don't support that, then it's incredibly frustrating and incredibly energy sapping. If the leadership structures and frameworks do support that, it can be empowering and explosive almost in the way that these things can expand and develop. The energy is already there where it needs to be in that operational spreading out to generate that cultural change. But right now, and this is a slight variation, I suppose I was going to say, I don't think, Omar, maybe it's a case of one little bit at a time here. I think it needs to be called out that the framework within which hospitals are governed is not properly following effectively the laws of health and safety. We have regulatory authorities in workplace health and safety that, broadly speaking and commonly, leave hospitals alone because they think they're governed by infection control people who understand health and safety, which is not necessarily the case. We don't have metrics from our providers, our funders and purchasers of hospital services don't provide boards the right metrics to demand from them workplace health and safety outcomes. Hospital boards do not currently use the right metrics to measure their own performance that includes workplace health and safety. So these things are from the top. Now, what you have, when you have these situations, you have hospital boards that aren't focusing on workplace health and safety. They're not requiring their chief executives and their executive teams to do it. In the executive teams in hospitals, I'll just say this last thing, in the executive teams in hospitals, you don't find highly paid health and safety expertise that can actually drive health and safety frameworks. So if you don't fix it at the top, this stuff becomes, really tough for the people with all the passion and the energy.
Thanks, David. Well, they're really important points, and I think I'm sure you could fill a day with the information in your head, and we definitely need to pay attention to it because it is the framework in which we can start to move. But I wanted to move just to a slightly different perspective, which has been raised today, and that is that with all of crises, environmental disasters, some people are affected more than others. And I know, Marie, this is a special interest of yours, and I'd like to give you the opportunity to tell us what you've been working on, please.
Thanks, Tracy. So I think this last session is really about what can each of us take back to our own organisation. And what I would really encourage all of you to do is to go back to your organisation and ask, who are the most vulnerable people that I work with? I think the pandemic has really fractured a lot of existing cracks within the healthcare system. And some of those cracks can let in some light, but some of those cracks can also widen disparities. So please, just think about who it is in your organisation, whether it's international medical graduates for whom all of the disruption to exams doesn't just mean an extra year of training, but may actually be influencing their visa status in Australia, whether it's medical students who've had an incredibly difficult year and just need somebody to reach out to them, whether it's the night shift nurses who may not have been there during the day for a lot of the support and care, whether it's some sole practitioners that you work with. I've been working in aged care this year, and it's just been so important to us to listen to our caregivers and our cleaners about what they really need. And what they said to us is that they needed to know that their families were safe, and they needed to know that their colleagues were okay. So, you know, our wellness priorities, it's not a very conventional wellness program, but our wellness priorities were to make sure that people were working shifts that could support their childcare arrangements if they were schooling from home. And also to make sure that sick leave was covered. We employed an extra 120 staff so that our caregivers and nurses could take sick leave and know that somebody would be there covering them. So just, you know, please go back. And I think if there's one thing this pandemic has taught us, it's how things spread. We've all learned so much about epidemiology. And I think I love Jane's idea of the pandemic kindness, because we know from this virus what makes things spread and how you stop the spread. And to stop the spread, what we've done is we've reduced contact with people, and we've put up borders, and we've looked for medicines and vaccines to make people less vulnerable. But what all of us want to do here today is we want to increase the spread of our great ideas. So we just need to flip all of that on its head. So we know that things spread when we have contact. So we need to reach out and have contact with each other. We know that things spread when the borders are open. So it's so great to have our international colleagues here today and to open those borders. And we know that things can spread when people are vulnerable. And so it's actually okay to be vulnerable to allow these great ideas to spread.
Thanks, Maria. There's a question that has come up during the day about that there's over 1,000 people registered for this symposium, but we're assuming that we all get it. How do we reach those people who we think may not get it yet? Just to continue on.
We need to look at an epidemic curve, and if every one of the 1,000 people registered today speaks to 5 people that we know, if we pick up the phone or have a cup of coffee to check that people are okay, to see how they're going, to share some of these ideas from today, then we've reached 5,000 people. And if each of those people contacts 5 people who they know to see how they're traveling and see what support they need and see what would make a difference in their workplace, that's suddenly 25,000 people that we've reached. And we've heard so many powerful examples today of the difference that one conversation can make. You know, Andy Tagg with that one phone call from a friend at the moment when they need it at the most. And Claire Skinner, you know, talking about sort of an opportune conversation that changed the whole course of her career. So, you know, I think we've seen those epidemic curves, and we need to turn this into an epidemic of kindness and care and transformation.
Thanks very much, Maria. I might ask the same question of David as well. You know, what can we do to influence the people who aren't here today? And if you want to reflect on any of the messages you've heard today as well.
Look, I think it's. I think there's different layers to this. I mean, Murray just provided a fantastic sort of expression. I see people in here. I see Kath Crock has been in talking, you know, and the gathering of kindness work that Kath's organisation's done, and I'm an absolute believer in that. The energy behind what's been talked about there about spreading the word. Systemic change is a different animal. It requires a certain kind of advocacy. I think just to give an example, the Victorian Healthcare Worker Task Force was created. In the beginning of that, there was no health and safety perspective at all. Initially, it was just, oh, well, how are we managing infection control? Then we became the health and safety camp. And now the conversation for the next stage of the Healthcare Worker Task Force is, how do we change the culture of health and safety in hospitals? So you can take people along a journey. I'm talking about those higher level things, and that requires organisations and people like Omar and the AMA and getting together with the Institute and the other groups, and you mentioned Susie New and the anaesthetists and the Australian Institute of Occupational Hygiene. One of the things that I have found in terms of getting and finding like-minded people, one of the things that COVID-19 has delivered, it's delivered to the Institute new coalitions. And those coalitions can be influential. And we found our way into the National Australian Commission on Quality and Standards in Healthcare, reviewing their standard. And now we've got health and safety people on the new national group that's advising ICEG, which is good because the ICEG doesn't understand the problem. So it's all about our organisations actually stepping up and doing our job properly, finding out how to influence people. One of the problems that you deal with is there's the way we've always done things. There is a bureaucratic culture. There is a standards culture, you know, the way we do things around here. And there are people in control of those cultures and people who in positions of influence in those cultures. And the reason why something is called the status quo is because there's a conspiracy of agreement amongst at least 50% of those in influence and power that things are the way they should be. Now, if you want to change something, you have to lean against that status quo and you have to be smart about it, and you must win hearts and minds. You can't just make a loud noise. You've got to work out where the influence levers are, and you've got to pull on those in very particular kinds of ways. So that's the strategic job of people who want to change culture from the top. I sit here and I say, culture comes from the top, cultural change is enabled from the top. Well, if I'm going to put my time and my energy where my mouth is, that means that the Institute needs to get together with organisations like the AMA and others and work out just how we will strategise this change and what outcomes, what outputs and what outcomes we really want. So, you know, we have to get together to try to create the systems change from the top that enables the sorts of things that Murray was just talking about then, and that sort of explosive energy and fantastic goodwill that's coming out of the field right now. There's just energy for change, which is fantastic.
Thanks very much, David. Omar, would you like to just briefly reflect on the day and how we can influence the non-1,000 people that are here?
Yeah, well, I think we've heard the two directions already that we need to be coming from. So certainly from the top, we need to hold our boards to account. We need to create a system where we're measuring what's actually important in healthcare. At the moment, we seem to measure dollars. I mean, we measure the volume of care. We don't actually measure quality of care terribly much. And we don't measure our staff well-being, outcomes, health, etc. So boards, as was mentioned, aren't ready, and they need to be required to get into that space. And I think that will push it from the top. And we are seeing a little bit of movement, and we just need to keep that fired up. But also, we need to drive it from the other end. We need to drive it within all of our various bodies, as individuals and as collectives. And I think the epidemic of kindness is a great way to reflect on that. And you know, it is happening. It's just not happening enough. So we need to. Everybody here needs to go and do their bit, and certainly the AMA will be doing our bit. I'm very pleased to hear David's suggestions for working together more in the future on health and safety in our hospital setting, because it is actually, it's shameful that in fact hospitals, which are supposed to be places of healing and healthy environments, are actually for all sorts of reasons dangerous and toxic environments. So we need to do better.
Thank you, Omar. And Bethan, your final thoughts?
Well, look, two things, I guess, just following on from David and Omar. And I think taking that perspective of coming from the ground up approach, I mean, the two things that have really resonated in terms of how do you influence others, I think we've got to move from the anecdote experience and have some data around this. And so I think we do need to look at, you know, what to measure and how can we harmoniously do that? How can we do that together and measure the same thing so we can benchmark off each other? So I think that would be one sort of take home message from today in terms of being able to influence both up and down, because we're talking about, you know, clinician engagement in wellbeing, as well as trying to get our, you know, key stakeholders and policymakers. And all parties are responsive to, you know, they want to see the data at the end of the day to create change. I think my last take-home point, and you know, it's wonderful to hear leadership being talked about so much, because I 100% agree. It's the key to cultural change, and within an organization, you know, the leadership happens at all levels, but I think, you know, the guardians of the culture in hospital healthcare organizations are largely heads of department in many ways. And I think, you know, we need to start thinking about the framework that David talked about. You know, what should we be setting up? What should we be selecting? And how do we train these leaders of the future? Like, what should we do in med school now so that we are not going to have 50 to 60 to 80% burnout rates of our staff going forward? What sort of self-led skills, self-awareness skills, interpersonal skills that we're not currently training in leaders do we need to not dealing with the problem, you know, after it sort of exited the station, so to speak?
Thank you very much, Bethan. And to deliver the hand back to Jane on time, I just want to quickly summarise, and I've got 1,000 post-it notes here of things I've learned and taken away. I think the important thing is, and the message I'm clearly hearing from David, is that we are on the side of right, that we as health workers, we deserve the same standards of health and safety as other workers. I heard that we have to find our friends amongst managers, executives and boards. It's only together that we're going to create really sustained change. I think we also have to measure some things that really matter to all of us, so that we create a really authentic intention to change and tip the scales from the 50% over the 50% that we need to get the ball rolling. We need to tell stories. We're all human. We need to spread kindness. And above all, I think now is the moment. That's what I'm hearing. Now's the moment. And I want to just say thank you to Jane, because there may not be another opportunity to bring us all together. And if there is any exemplar of an influencer, then it's Jane Munro. So thank you very, very much, Jane, for all you've done. And I'd like to hand back to you. And thank you to all the panel.
Thank you, Tracy. Thank you to the panel. Thank you for that. I am so delighted with how today went, and thank you all for your many, many messages and comments throughout the day. And someone summarised it beautifully. It's not many symposiums where back to back the talks are just smash one after the other of just stellar content of incredible speakers. And when we put this together, we wanted, I think I said earlier, people to get goosebumps. That was the sort of the mark of how we wanted to ask our speakers, and the standard for when we were inviting people. And we were and the second was for diversity and mix of a whole lot of things across our country and background, and trying to get representation both within and out of healthcare and medicine. And I really think that today I felt we've had such a great day moving through, reflecting on our experiences here and internationally, how COVID has affected us, and on the background of several decades of I really do feel like losing a bit of the humanity in healthcare and that impact on us as clinicians. Then the session on connection I found very powerful. We were able to, learn obviously through those two sessions so much from the sharing so openly by all of the speakers that are involved. They were just stellar. I don't think anyone is going to forget Eric's mad, I'm going to say it wrong now, but mad, sad, bad. I think he added in possibly glad. And then Andy Tagg's incredible vulnerability and sharing, which we've had a lot of feedback about, and Susie New talking about her advocacy work, which I know she possibly undersold, I think, because she's been to Turner and Glenn Horton with their incredible work for the UK, and really, I think, giving us particularly perspectives on thinking about culture change, which sets the tone for the rest of the day. For me, Shahina Bragnaza thinking about connection, because spreading kindness and thinking about the importance of that for us in our daily work, in our personal lives, is so important. Kim, Margaret and Hash, their insights when we think about how we care for each other, blowing apart some myths, and their deep experience working with other clinicians is really important. And I think having all of their different perspectives was really valuable. So thank you. And then powerhouse of Claire Skinner with leadership and power with change, and Simon Fleming talking about culture was just so valuable. And I hope you took a lot away from that. And there was lots to digest. And of course, this most recent session, I've still got goosebumps thinking of what Jill was talking about, and then this recent panel, which I think had lots of meaty insights about practical suggestions for how we can change the system. And Tracy summarised that beautifully, but particularly the thoughts about using data and heart and leaning in to the hard work. It is going to be hard work, but it's the work that I think that we're ready to do. I agree that COVID, it's one of the COVID silver linings, I think. I often say now my inbox is full from everything from Boost Juice to, 3 emails from 3 different institutions about wellbeing every single day or second day. But I do think it has primed everyone to be talking about wellbeing and mental health. We're literate about talking about wellbeing, and as Margaret talked about, it's gone from the back room with rare genetic diseases to actually front of house plenaries. We're having full day sessions, and we smashed out 1,000 people, sold out, if you like, to a free full day seminar here, and many requests to access this. And it's because we care. We realise this is important, and I think we're ready. We're ready as an industry, we're ready as a community. And so what I would really ask of us all is to use this opportunity. We don't want to waste it. We don't want to waste the opportunity of having Omar as our president. He's on board, he's listening, he's interested. Our organisations are interested. We've got David in the leader, and I agree with him. We've harnessed this coalition now, and there's been part of the task force. We've all come together with a lot of new links. This awareness, the fact, even though my mum was an occupational physician and I did her typing all through med school, so I was very aware of occupational health and safety. I've learnt way more about that in the past 4 months than I ever hope I ever need to again. But the fact that many boards and many CEOs probably didn't know what the precautionary principle was until maybe even now, unfortunately. But, precautionary principle was, or had read the SARS report even a few months into the Commission report into this pandemic, it's a problem. So we've got lots of issues around occupational health and safety for us as healthcare workers, but bigger cultural issues about how we care for each other. And the fact that we need to just the background issues around burnout and culture and civility, and just, I think, line in the sand that we say we're going to do something about that. And if I think that example Marie gave was, if one of us reaches out to 5 people and really engages with those 5 people, and we get wellbeing literate and leaders and they engage with another 5, that ripple effect is going to be huge. We can do this together. It does take leadership, it takes skills. Bethan gave fantastic 5-minute answer, potted summary of the whole Stanford course and her 5 years of work in this space. And sometimes there's some barriers where you won't have executives that are on board, and that's where we can form coalitions and help and work together on that, and that's important. But it comes back to me that our people are everything. Our people are everything. We can't care for patients if we're not well. We can't pour from an empty cup. So lift your gaze, connect together, keep wrapping your arms around each other, learn how to look after yourself. Learn how to look after yourself. We are really crap at that as doctors generally, okay? Please learn how to look after yourself, whether you're a 25-year-old medical student or a 75-year-old doctor. Please learn how to look after yourself. Learn how to look after your mates and your teammates. Learn how to be a good boss. Don't be a dickhead boss, okay? If you're a boss, learn how to be a good boss. Learn those skills and work out how to support your leaders. And if you're a leader, get some good training around that. And let's work together to spread kindness and better culture change, improve diversity in our leadership group, make sure the right voices are at the table. I'm just going to finish with the last thing to say absolute thank you to the Rockstar steering group that has helped in, as I said, boots and all. Secondly, to say massive thank you to all the speakers and panelists and people that participated today. I must finish to say thank you to David Pethick and Gus Fraser, the behind the scenes tech fabuloso team from the Department of Peas and at RCH. and the Uni Melbourne and Department of Peds have supported this, which has been fantastic. We've got the fantastic partners as well. They've been awesome, but it's just been a joy to be pulling this together. And I really am going to finish off the day by saying, let's do this, everyone, work together, and hopefully we'll do something else next year and pull something together so we can keep building the community. So thank you all for participating.